Welcome back to the Explainer series. Make sure to like, share, and subscribe to Decode Healthcare with Harshal, as today we are diving headfirst into Section IC of the ICD-10-CM official guidelines. We're going to conquer 5 highly tested, absolute high-yield chapters that you need to know for your CPC exam. Here is our ultimate survival syllabus for today. We're covering 1. Infections, 2. Neoplasms, 3. Diabetes mellitus, 4. The circulatory system, and 5. Pregnancy rules. All right, diving right into Section 1, Chapter 1, Guidelines for Infectious and Parasitic Diseases. Identifying the exact status of an infectious disease can literally make or break your code selection. A huge exam trap here is HIV sequencing, so you really have to lock this in. B20 takes priority, and it's sequenced first if a patient is being treated for an HIV-related illness, but if they're simply HIV positive and totally asymptomatic, Z21 is your only correct choice. And if the lab tests come back inconclusive, you just default to R75. Now, a crucial area we absolutely need to look at is how we handle sepsis, severe sepsis, and septic shock. Mandatory sequencing dictates a very specific chain here. Step 1, you must assign the underlying systemic infection code first. Step 2, you follow that up with the specific R65.2X severe sepsis code. And finally, Step 3, you list any associated organ dysfunctions. Never mix that order up. And this is exactly why you can never ever forget your secondary codes. Always remember to append codes like Z16 to capture antimicrobial resistance, or B95 through B97 for infections classified elsewhere. It completes the full clinical picture. Moving right along to Section 2, let's look at Chapter 2, Guidelines for Neoplasms. Navigating the neoplasm table correctly is an absolute game changer for passing the CPC exam. You must master these specific columns. Why? Well, imagine a cancer patient comes in. Your sequencing completely shifts based on the primary reason for that specific encounter. Are they treating the primary original site, a secondary metastatic spread, or maybe a complication like anemia or dehydration? The column you choose changes everything about your code. For instance, if the sole purpose of the visit is cancer therapy, those Z51 encounter codes, whether that's radiation, chemotherapy, or immunotherapy, they must be assigned as your primary diagnosis, followed by the specific malignancy code. Okay, Section 3, let's talk endocrine and metabolic diseases, specifically focusing on Chapter 4, Guidelines for Diabetes mellitus. You need to understand these distinct diabetes categories inside and out, and always keep this golden rule in mind. If the medical documentation does not specify the exact type of diabetes, Type 2, which is the E11 category, is your automatic default. Now, what's really fascinating here is the mandatory use of combination codes. The guidelines automatically assume a linked relationship with conditions like neuropathy or chronic kidney disease. So you cannot split codes when a single combination E code fully captures both the diabetes type and its associated manifestation. Furthermore, whenever it's applicable, you must append these specific secondary Z codes to indicate the long-term use of insulin or oral hypoglycemics. It proves exactly how the condition is being managed day to day. Up next, Section 4, Chapter 9, Guidelines covering diseases of the circulatory system. Chapter 9 is packed with hidden assumptions that you simply have to memorize. For example, unless the provider explicitly states otherwise, ICD-10-CM automatically assumes a direct causal relationship between hypertension and kidney or heart disease. You link them with combination codes, no extra documentation required. When coding heart attacks, it is absolutely vital to clearly differentiate a Type 1 spontaneous acute myocardial infarction from a Type 2 AMI. They are completely different. Type 2 is caused by an underlying oxygen supply and demand mismatch. You've got an absolute 4-week, 28-day rule here. Anything happening within this 28-day window is coded as an acute MI from category I-21. The very moment you hit day 29 or after, it requires a subsequent or old healed code. Finally, Section 5. Let's tackle Chapter 15, Guidelines for Pregnancy, Childbirth, and the Puerperium. This chapter dictates strict, unbending rules for maternal records. If you take away anything from this explainer today, know this override rule. Chapter 15 pregnancy codes will always bump codes from all other chapters down the sequencing list. If a pregnant patient comes in for a seemingly unrelated condition, that Chapter 15 code still leads. On top of that,
Every single maternal delivery record requires precise seventh character extensions to denote the specific trimester. Plus, you must assign mandatory secondary Z codes on all delivery records to capture the exact outcome of the delivery and the precise weeks of gestation.
Go ahead and take a screenshot of this one-page visual summary cheat sheet right now. Keep it handy because it locks in the definitive solutions to the trickiest chapter-specific guidelines you're going to face. But wait, if Chapter 15 overrides absolutely everything, what happens when a patient is injured or poisoned? Are you prepared to navigate the chaotic coding of adverse effects and underdosing? Tune into Part 72 to decode external causes. Think about it. How accurately could you code a complex injury right now without making a fatal sequencing error? We'll see you in the next one.